When?
75-cent.
Oh, they do sell them?
In that gift shop.
21.
Tiny, right? It's okay. Nothing.
I love the beer.
Thank you.
Call the House Committee on
Yeah.
Healthcare to order
Getting older.
on this lovely day in May, the
Special
21st of the
session
month.
stress.
First, I want to apologize to everybody. It's obviously not my fault, it's somebody else's fault.
Oh, good for you.
It's usually the way I start these kind of things. It really has been sort of chaotic today, as you know. We've now gotten through on the floors. We've allotted about an hour, which will take up a report from DCBS and OHA. We've allotted DCBS about 15 minutes. We'll ask them to start, and then OHA can use up the rest of the hour. We will not have time to get to everything on the agenda. I'll ask you, if we haven't gotten to something that's important to you, please ask Mr. Allen and his people, or Mr. Smith and his people to fill you in. We hope there'll be less chaos in September and we can get to some of these issues in a little more coherence. So let's start with Mr. Smith and DCBS. Can you join us? Insurance Commissioner to talk to.
Good afternoon, Chair Greenlick, members of the committee. For the record, I'm Cameron Smith, the Director of the Department of Consumer and Business Services. And while Director Pat Allen wanted me to use his slides and expound for an hour on our perspective on CCO 2.0, we're going to give a quick update on the reinsurance program, and then I'll hand over to Andrew Stolfi on the Oregon marketplace.
Actually, we were worried that he's stealing all your people.
Staff. Yeah.
It's back and forth. For our reinsurance program, we just got a state hospital, a new policy analyst and program analyst from the state hospital. So back and forth. So as all of you know, our reinsurance program funded through the insurance assessment, both the federal 1332 waiver funds and then also other state funds. Given that we had Measure 101 on the ballot previously, we delayed on the Rule Advisory Committee, have begun to convene that, and with that group we'll begin to set out the payment parameters, develop the process and timeline for paying claims, and then also ensuring program integrity through the audit process. So that work is ongoing. In terms of already having that reinsurance program baked into the 2018 rates and beginning to model that forward for the 2019 rates, have full funding for those first 2 years of the reinsurance program. And we'll be working with all of you and the governor's office in terms of what that looks like for the out years for the third year and fourth year, which will be in this next biennium, and then the fifth year will actually kick into the biennium after that. But in terms of since we last met, we had estimated that we would receive about $32 million in those federal fund 1332 waiver funds, but received notice that it came in at about $54.4 million of the federal funds. And in the aim to make it consistent, have not shifted. It was about 6% that we were able to hold down rates for 2018 and looking to keep that the same, adjusted for inflation going forward. But any of those extra funds that are not needed for that first or second year reinsurance will be applied to the third year going forward. We have made a first hire of our program analyst, and we'll also be hosting a post-award. CMS has a post-award forum requirement that we'll be aiming for June 28th as an opportunity for all to comment on the 1332 award and also the reinsurance program more generally. In terms of some of the structure to the program that we're looking to take to the rulemaking process, looking at a cap of $1 million to ensure there's no overlap with the federal risk adjustment. Look at a coinsurance rate of about 50% to align incentives so that all carriers are managing claims, and then an attachment point for 2018 of about $95,000, and then 2019 $90,000. But out of a lot of federal uncertainty, this reinsurance program is well supported both by insurance carriers and consumer advocates as one great tool in our toolbox to help hold down rates going forward. Happy to take any questions now, or we can also hand over to Andrew for a quick update on the broader market forces.
The million cap. Alicia, what specifically?
It would be a cap at $1 million for what could be reinsured up to $1 million. Thank you, Chair Greenlick.
Yes. Mr. Chair, members of the committee, for the record, my name is Andrew Stolfi. I'm the Administrator and Insurance Commissioner for the division. I'll speak to you today about a couple things around market stability efforts this year and next that we've taken and are planning. Could say that our activities generally fall into two categories: responding to federal changes and initiatives and trying to preserve the gains that have been made here in Oregon. I'll try to touch on four things quickly. The first two are responses to federal rulemaking. The first is in regard to association health plans and the rules that have been proposed around those. You may be aware of this. A rule proposed to alter several things. For example, relaxing a requirement that an association be formed for a purpose other than health care. And also relaxing rules to allow these associations to operate across state lines. We have submitted comments to the federal government in response to these proposed rulemakings, which we'd be glad to make available. We raised two concerns. The first are around potential negative impacts that this rule could have to the individual and small group market. And the second is to ensure that the state is not preempted in exercising the authority that we currently have over association health plans. The second rulemaking we responded to, and again, glad to make our comments available, is around short-term limited duration plans and a proposal by the federal government to extend the duration that those can be, which is currently 90 days, to up to 1 year. These plans, as you're probably aware, there's no requirement that they cover essential health benefits. There's no guaranteed issue. There's no renewability. The good news is last year, House Bill 234 was passed, which put into place in Oregon what is the current limit for short-term plans, which is that they can only go up to 90 days. The federal rulemaking has expressly said that it would not preempt state law. So our comments supported that and wanted to emphasize that whatever rules however the rule might be changed, that it would not preempt our ability in Oregon to regulate the market as we deem fit. Next issue I'll talk about is the 2019 rate review process, to give you an update about what's going on there. You may have seen that rates for 2019 were filed 1 week ago, last Monday. I'll give just a little background and some information on what we've seen in the process so you know what to expect. First, as far as background, I think it's important to emphasize that our health insurance market has traditionally been very competitive, and point out that last year's health insurer financial statements revealed a combined net income for our domestic health carriers of $195 million. This is an improvement from the net losses of $35 million in 2016 and even larger net losses of $217 million in 2015. In regards to enrollment in the individual market, we ended 2017 with close to 120,000 people enrolled on the exchange and nearly 73,000 people off the exchange, for a total of 192 or around 192,000 Oregonians. Quarter one of 2018, the most current numbers we have, show more than 136,000 on the exchange and around 60,000 off, for total enrollment of more than 196,000, or about a 2.5% increase from year-end 2017. We have 7 carriers offering on the individual market. 5 of those sell on and off the exchange, and 9 carriers offering in the small group. I mentioned the filings came in 1 week ago. There's a lengthy process we go through, our actuarial staff reviewing every single one of those in great detail. Some things that we did see on the individual market side, there are 7 insurers continuing to offer that have filed initial rate requests ranging from a 9.6% decrease to a 16.3% increase. As a reminder, the rates filed at this time last year were between a 6.9% and a 20.7% increase. Preliminary rate decisions last year were substantially different from the initial filings, with final approved rates coming in across the 7 carriers at between 3.5% and 19.2%.
What was your first impression of that rate spread?
It's something we're going to pay very close attention to, and our actuaries are going to dig into quite a bit over the next few weeks and months. It's lower. It's a starting point lower than last year.
The middle of the range is pretty narrow and pretty small.
Yes.
Outlier on each end, sort of.
Chair Green, that's correct. Yes, and we will have more information in the next few weeks and months as we dig into these. Good news along with this is that all the carriers offering in the individual market have not only maintained their current service areas, but we have 2 insurers who are increasing their coverage areas. Kaiser is moving into Lane County, and Pacific Source is moving into both Lane County and Yamhill County. On the small group side, we have 9 insurers offering who have requested initial rate increases from a 4% decrease to a 9.4% increase. Compare this to last year. Initial requests were between 1.8 and 8.5%, with final rate decisions between 3.3 and 10.1. You could just add, historically, this has been a stable market, and most of the carriers cover the entire state. Just emphasize again that these are the initial rate increases. History has shown us that these could both go up or down, and there's quite a lot of work to do in the next few weeks and months. Mention our actuaries will spend quite a lot of time on this, looking at all the assumptions that are included. Three I can point out, anticipating some questions around the effect of the individual mandate, reinsurance, and CSR loading. On the individual mandate, the carrier's estimated impact ranges from 1.2 to 11.5% increases. The 2018 rates, so current rates filed last year, did reflect about half of this impact already. So the final impact to the 2019 rates could be less than we've stated, the carriers have stated in the filings. Again, this is something we'll spend a lot of time on and more information to come. Reinsurance, as the director mentioned, we have a program that kept rates down around 6% for 2018. The carriers in their filings considered reinsurance requests in different ways, and it's going to take some time to review how the different carriers handled this and come to a conclusion on that. And finally, on the CSR loading, this was done a little differently by some of the carriers. 5 carriers estimated the CSR silver load to be about between 7 and 12.7%. 2 other carriers did not explicitly state the figure, but appear to have been around 7 to 8%. As a comparison, for last year, we instructed carriers to load a 7.1% surcharge. Next steps, rates are being posted to our website, OregonHealthRates.org, and are being reviewed. Public comments are welcome. June 11th and 12th, there'll be public conference calls. June 29th, preliminary rate decisions will come in. There'll be rate hearings, public rate hearings on the 9th and 10th of July, with the public comment period to close on the 10th of July. On July 19th, the proposed final decisions will be submitted to the commissioner and then made public after that. And from July 1st to the 15th, there'll be a reconsideration period if necessary. Last thing to comment on very briefly, we were recently awarded a grant of $282,000 by the federal government to conduct a rating area review. We currently have 7 geographic rating areas. These were put in place in the early 90s for the purpose of a small group reporting and have just been carried forward since then. So we're going to engage an outside firm to help us examine whether changes could be made to those rating areas with the goal of seeing how we can improve access to health care in rural Oregon. I'll stop there and be glad to take questions.
Any questions?
No, I do not.
Great. Well, thank you very much. I was intrigued with those rates.
Yeah, it's a wide range.
Yeah.
Right.
I think we were all glad to see those come in much more stable than we thought, Chair Greenlick and members of the committee, but still important for us to recognize what a significant chunk insurance premiums are for many Oregonians and their families, especially for those that aren't receiving the subsidy.
One of the things that I'd be interested in hearing, and we've had some conversation in the past about the inflation rate estimates. I'd be interested in hearing what inflation rate estimates are, what medical trend estimates are in those underlying rates. I still think we ought to be able to figure out how to do that beforehand and give that to our
That's right.
insurance companies rather than the other way around. Thank you both very much.
Thank you, Mr. Chair.
Thanks for the great job you're doing. In spite of the fact that Alan took all your staff. Sir Alan, will you join us?
They match your jacket.
I know. Sounds great.
Thank you, Chair Greenlick, members of the committee. Patrick Allen, Director of the Oregon Health Authority. For the record, I took 2 people out of 1,000 with me, just to clear that up. We have, it seems like over the last week we've been working on a longer and longer list of things to talk about with a shrinking time slot, so we're going to cover an awful lot of stuff really quickly. I'd like to start first off, though, by asking the new superintendent of the state hospital, Dolly Matteucci, to introduce herself to you and the committee. We're delighted to have been able to attract someone of her caliber to this position. It's one that we've been working hard to fill for better than a year and a half. And so with that, I'd like to turn to Dolly for a quick introduction.
Chair Greenlick, members of the committee, for the record, my name is Dolly Matteucci, and I'm the new superintendent at Oregon State Hospital. I'm excited to be here at my first appearance before the Oregon legislature, and I appreciate the opportunity to have a few minutes to introduce myself to you, the Healthcare Committee. I'm privileged to serve as the superintendent of Oregon State Hospital. I had my first glimpse of the hospital in 2014 when Oregon hosted the annual Western Psychiatric State Hospital Association conference. At that conference, Superintendent Greg Roberts and his team told us of the history of the hospital and its transformation both inside and out. I remember walking through the halls of the hospital and feeling this tremendous sense of hope and recovery, and the collaboration I saw between patients and caregivers was very moving and incredibly different to my experience to date. I was impressed by the person-centered culture that was apparent, the emphasis on trauma-informed approach, which is expanding not only to patients but to staff, and the culture of continuous performance improvement. Since that day in 2014, Oregon State Hospital has improved even more. Shortly before I started, I learned of the successful results of their most recent Triennial Joint Commission survey, which is the hospital's accreditation agency. The results were amazing, the surveyors encouraging the hospital to actually open a center of excellence so other psychiatric facilities could learn from their success. I would like to take a moment to thank the Oregon legislatures for their contributions to that success and the support they've shown the hospital over the years. My journey to Oregon started approximately 28 years ago at Napa State Hospital. I started there after completing my BS in dietetics as a dietetic intern. I knew of the hospital, but I had no idea of what a long-term psychiatric facility did. But it did not take me long to fall in love with the work that happened there. I found my passion in the field, and I've pretty much been there ever since until making this move. I worked my way up the hospital system, holding a variety of leadership positions, culminating in the last 8 years serving as executive director, which is parallel to the superintendent position here. Napa is a large inpatient facility with more than 2,300 staff, serving over 1,200 patients daily. Those patients are under both civil as well as forensic commitments. Like Oregon State Hospital, Napa is part of a behavioral health continuum and is impacted by the ability for communities to provide services and support both pre-hospitalization and post. So I understand the challenges of building a seamless integration into that continuum. I bring a deep understanding of state hospitals and an absolute passion for the work that they do. I believe in and I'm dedicated to the principle that state hospital treatment and services is just one step in the journey of recovery. And the hospital event is grounded in patient-centered care, recovery and healing for all, and the focus on community reintegration, and that focus starts at the initiation of admission with discharge planning, and that it is person-centered and focused on the needs and wants and strengths of the patient. The patient voice, both individual as well as collective, is key to designing programs, policies, and opportunities within a state hospital that promote a healthy and inclusive environment for recovery. To that end, I've initiated efforts with our Patient Advisory Council to see how we could make the existing Patient Governance Council even more robust and a stronger voice at the hospital. As a leader, I'm analytical and systematic in my approach, and it's one of the things I appreciate about Oregon State Hospital is their sophisticated performance management system. They do in-depth strategic planning and mapping of core processes across the hospital and use metrics to measure success. I recently had the opportunity to attend a quarterly performance review, and I was impressed with the measures the hospital uses to track both its clinical care and its business operations. I believe strongly in collaboration with patients and staff, as well as our community stakeholders. I depend on diverse perspectives, the knowledge of subject matter experts, and partners to inform my work. My experience and philosophy align with the mission and vision of Oregon State Hospital, and I'm dedicated to learning the laws, rules, and cultures of both the hospital as well as Oregon. It is my goal to leverage my experience and ensure the ongoing trajectory of the hospital's transformation. I'm meeting and listening to patients, staff, and stakeholders to better understand the moving parts of Oregon State Hospital here in the Oregon community and how they all fit together. I'm learning what makes Oregon State Hospital unique and how I can help the hospital to continue to build on its success. As superintendent, I'm a member of the OHA leadership team dedicated to improving the health of all Oregonians, and I embrace the work of the agency, and it is my first time working for Director Allen. I'm honored as well as humbled to serve the people of Oregon, and I look forward to working with the state leadership to ensure the hospital stays on the right path. I welcome any questions you may have, and I thank you for your time today.
I sit on the advisory committee of the hospital, and it's quite an extraordinary place. I would urge you all, if you haven't been to the hospital, it'd be an extraordinary, very pleasant visit, and I would urge you to take the opportunity, and Dolly staff will be glad to help orient you. It's quite an amazing place. Are there any questions?
Just a comment, Mr. Chair.
Please.
Welcome to Oregon. You have a
Thank you.
fantastic history for this job, and we're very lucky to have you. Thank you for your presentation.
Thank you very much.
Thank you.
All right.
Thank you, Chair. Thank you, members.
So we'll move on to the next topic. I wanted to draw your attention to on OLIS, a letter dated May 21st having to do with the recoupment of payments to coordinated care organizations made an error on the dual eligibles issue. We've talked about this a couple of times. This was initially identified as about a $74 million problem. We indicated at that time that we needed to do significantly more research and work to understand what had happened and its true scope. We've actually been able to narrow that down to a $41 million problem, so significantly less than we initially thought. We've now begun the recoupment process, and statements are out to the coordinated care organizations, and they're working on their repayments to us. This is detailed in the letter, and on the second page there's a by CCO and dental care organization as well. At the time some of this occurred, DCOs were directly under contract with us. Now they're all subcontracted through CCOs, but that per entity detailing is there. We're also we've worked out a plan with the Centers for Medicare and Medicaid Services in terms of our refinancing back to them for the dollar amounts, and that process is underway as well. So this, and then of course we've taken the steps necessary to assure that, they had been taken some time ago to assure that this particular kind of an error is not, it's been addressed in our systems. So with that, I'd be happy to answer questions about that.
Paragraph, what happened now that you've had a chance to look back at it?
In a paragraph, what happened is in the initial sign-up of people in the expansion population to the Oregon Health Plan, because of its manual nature, we failed to capture data necessary to be able to identify people as dual eligibles during that process. The Medicaid Management Information System is itself not robust enough to be able to, in an automated fashion, discover those kinds of pervasive data errors, and so they have to come to light through other processes. When they came to light, it took us too long to be able to identify that problem and address it, though it was ultimately addressed. And then we had some challenges in the documentation of decision making along the way to be able to show what kinds of discussions or agreements had occurred with CCOs. It's important to point out that while these payments were payments made in error, claims were also paid by CCOs, prescriptions were filled by CCOs, and we're in a little bit of an unfortunate circumstance that their only recourse right now, if they choose to, is to go back to providers who they in turn paid claims to that should have been paid by Medicare. That's going to be difficult, if it's possible at all, for them to do. And in areas like prescription coverage, that money is out the door, and they're not able to recoup that. So this is really a mixed bag entirely of our causing through this data error that occurred.
But they were legitimate services that were provided
Absolutely.
by the CCOs. They were just paid the wrong way.
Yep. Yep.
Question on that, Todd?
Rep Bueller has a question.
Representative Bueller.
Thanks, Chair. Pat, were you able to determine who made the initial determination and payment to CMS for the $15 million in 2016? And
Yeah, the documentation challenge that we've had has been difficult, and no, we've not been able to identify specific individuals.
So let me be clear, we paid back $15 million to CMS without clear documentation of who made that decision and who they reported to.
That's correct.
Do you find that disturbing?
That we paid the money back to CMS?
That you do not know who made the call of paying back $15 million and who they report to, and what's the change of command?
That's the kind of decision making that I would prefer to document. Yes.
Thank you.
Shall we move on?
Chair Greenleaf, members of the committee, for the record, Jeremy Vandehey, I'm the Director for Health Policy Analytics at OHA, and going to give you a quick update on CCO 2.0. I know this is a topic that you all care a lot about, and I'm not going to do it justice today in the 7, 8, 10 minutes that I've got. So happy to do a deeper dive with anybody who would like that over the summer on as we're moving forward. Generally, just
I think we'd all like it, Jeremy. So it's fine.
I'm sorry, Chair.
I think we'd all like a deeper dive on an ongoing basis.
Perfect, and we'd like to keep you in the loop as well. So we'll make sure we get that scheduled.
Individually.
I think we've got one time at the end of May, but we'll keep reaching out so we can keep you in the loop. So generally, this CCO 2.0 process is what we're calling building up to the next phase of CCO contracts. I think, as you all know, the current CCO contracts will end at the end of this year. We're extending them for 1 year, so they'll end in 2019. And that really what that 1 year is doing is buying us some time to be more thoughtful in terms of thinking about how much progress we've made with CCOs over the last 6 years, and be really clear about where do we want the model to be at over the next 5-year contract. So this year is really our policy development and public input year. And then next year is really going to be the procurement process, and then contracts will be awarded next summer, and new contracts will start January 1, 2020. So seems like a ways away, but things are happening fast, and probably take 2 years if we had it.
Yeah, if I could just comment on that. When we were first considering this delay, the feedback I pretty consistently got was, well, don't just delay to delay, be sure you get something for it, and we're going to use every darn day between now and January of 2020 to be ready for that. process. Is this a queue that we're running behind?
No.
You're not. Nobody wants to look at us anymore. So we've broken down this year into 3 phases. The first, well, let me back up. The governor's really asked us to look at 4 different areas, and she's asked the Health Policy Board to lead this process around setting the clear goals in those 4 areas. And those are continued cost containment, improving social determinants of health and equity, improving behavioral health, and improving value-based payment, moving further away from fee-for-service to payments for value and based on performance. So we've really structured this year, in particular, looking at those 4 areas. We're looking at other areas as well, but we've got our first phase, which really happened from earlier this spring till about now, of casting a wide net in terms of where we could be improving in those 4 areas. And we're looking at things not just in terms of new shiny objects, but thinking about what did we have in the initial round of contracts, how much progress did we make, where have we not accomplished where we wanted to, and is that on the part of the CCOs, on the part of the agency, or what? And then where do we really want to set our sights out over the next 5 years? We started this spring really with casting a pretty broad net. Have done a ton of stakeholder outreach, I think around 50 or 60 public meetings with various work groups and committees that the agency has. We just completed 4 public forums. We've done a survey, which we got about 1,600 responses back. So that's kind of our first stage. The next stage that we're moving into, phase 2, is taking those ideas and running them through a kind of feasibility and impact analysis to see, really how difficult are these? What do they cost? What do we think the impact is going to be in terms of moving the needle on the triple aim goals of improving health, improving quality, and lowering costs? So we're doing that analysis. We'll be narrowing some of these ideas down through June and July, and we'll be through an iterative process with the Health Policy Board at their July, August, September meetings of narrowing that list of recommendations down until they've got a final set for the agency in September, October. We'll then take that final set of recommendations and start to draft a request for applications at the end of this fall. I've submitted on OLIS a list of, you can go ahead, a longer 16-page list of the ideas we're kicking around in those 4 areas, and some of those are staff-driven. Some of them have been coming in through stakeholder input as well. And you'll see it's a pretty wide net. I mean, everything from things that would actually require more financial resources to really tweaks on current language in the contracts, and that feasibility analysis that we're going to start to do will help delineate, are these really big things that we're asking, or really just tweaks on the current system.
Thank you, Chair. Just want to, if you could expand on your public input. As you know, I'm always curious to know how those are presented. Are they done in multiple languages? Can you expand on that, please? I
can. So we've, and I'll probably have to get back to you with all of the details, Representative, but we have done the survey, and I believe it was at least in English and in Spanish. It was a survey we pushed out through SurveyMonkey tool to a broad, our big listserv that we have, and then asked folks to forward it on. We received about 1,700 responses back. We have a member survey out in the field right now that we've also started, and are collecting real data information on that so that we can get a better sense of who we're reaching and where the gaps are. We did 4 town halls. All of them were either Pat or I who facilitated them in English, but we did have interpreters there as well. I'm happy to get you some of the details if you'd like.
That would be great. Thanks.
So I won't go through all of the options that we're considering, but just to give you a bit of a flavor, and like I said, there's a document on OLIS that goes through this in more detail. But in terms of value-based payments, things we're thinking at are, should there be a minimum threshold for the next round of CCOs in terms of the amount that they're paying providers on value, and what would be the expectation at the end of that contract period. So it's things of that nature that we're thinking about.
Jeremy, are you dealing with big structural questions like, are you opening up the competition? Will there be more CCOs, possibly less CCOs, possibly? I mean, dealing with that kind of level yet?
So it's Chair Greenlee, it's a good segue to my next slide, actually. So there's a couple of decision points that while the policy board is really focused on the policy goals that we've started to hone in on and needing to make decisions on because they really frame how the procurement is set. So there's two decisions that we've landed on and we'll be announcing these formally in June through a notice for contract, a notice for upcoming contract period, which is sort of a early notice before the actual procurement starts. And those two decisions were one, to do a request for application instead of a request for proposals. So a proposal process, usually it's a competitive process, and you usually pick a number of applicants and you say, I'm going to take my top 5 and that's it. An application process, you set your expectations and goals, and then you'll take those who are qualified applicants. And the latter is what we did in 2012, and we've looked at the pros and cons of both and have landed back on a request for application process for the upcoming procurement. The second piece had to do with who could apply. We looked at a various number of options within this and have landed on a footprint. Any organization that has a current footprint in Oregon. So those would be organizations who currently have a certificate of authority from DCBS, current CCOs, tribes, a variation of those organizations if they kind of wanted to reconstruct themselves. So we wanted to open it up beyond the current CCOs, but believe we've got enough players within the state that we don't need to open it up to folks who aren't already here serving the healthcare system. Does that answer your question?
Not quite.
Not quite.
Folks serving the healthcare system in a CCO form, or people serving clients in Oregon that might be different than an existing organization.
So that
Health Share, as an example, was not in existence, but the elements of it were in existence. Would that be the kind of nature?
Yeah, Chair Greenlee, so we're thinking about footprint here in Oregon as meaning a healthcare footprint in Oregon, so not necessarily a current Medicaid footprint.
I got you.
I already hit on some of these pieces around the public engagement. This is ongoing. As I mentioned, there's a member survey out in the field right now. We'll be out back on the road for a road show, we're calling it, at the end of June. We're going to do another round of public input if anybody would like to join us, and we'll certainly let you know if we're in your district.
It'll be 10 or 12 cities across Oregon.
Can I ask another question, please? Thank you. Did you ask any questions and get any responses about dental care or oral health?
Chair Greenlee, Representative Kennedy, I have to go back and look and see what we asked specifically about oral health. I do believe that we asked some questions in terms of prioritizing some work, but I have to go back and look at exactly what those were. We've been mostly focused on the 4 areas in the governor's letter, but oral health has been one where folks have said, well, what about oral health? And generally, my response has been, the governor's asked us to look at 4 specific areas, but that doesn't mean that we aren't continuing to try to move the needle on all of the rest of the goals of the CCL model.
Follow up, please. So I would love it if you could get back to us and tell me anything about that, as well as prenatal care, please.
Sure, absolutely.
Thank you.
And then we've just got some links we got a website up that has all of our information listed, and if folks can't figure out how to engage, the default way is to send us an email. So.
Okay. Any other questions, Jeremy?
Chair, I have one last question.
Yes, go ahead.
Thank you, Chair. Is the online survey available to everybody, or is it only given to whomever you guys have identified to take the survey?
Yeah, Chair Greenlee, Representative Alonzo Leon, both surveys have been open to anybody. The first survey, we sort of focused on our broad stakeholder email list, and the second one, the member survey, we're trying to work through CCOs, provider networks, community advisory councils to get that out to members.
Okay, thank you.
Just a quick comment, Mr. Chair. I just point out to the members of the committee, I'm not reading it online yet, but Jeremy Vandehey has posted this 2.0 draft policy options, and there's a lot of detail in those 10 pages of different things they're looking at, and we should probably read it.
Good idea.
We're asking questions.
Well, I mean, he gave a very surface, it's a very high level, and there's, if you look at, you can see the things that they're considering or weighing, and we should probably read it and maybe check back in September when we're back together.
Or before.
Before, yeah.
Right.
All right, thank you. We'll move on to the next topic then. A couple of things that are related to each other. You may recall at various times we've been talking about a reorganization in the agency to address some organizational weaknesses that I identified when I first arrived at the Health Authority. We have now actually rolled out a draft of that reorganization at the 1st of May to our staff internally and to stakeholders. And I'd like to give you a little bit of a thumbnail of what that entails. Two significant weaknesses that I've found to be the case in the agency. One is that the Medicaid director, as we sit today, doesn't actually manage the Medicaid program. The Medicaid director is a policy position with no staff and no resources, and the actual operation of the Oregon Health Plan is in a different part of the organization. That creates some, to me, fairly obvious operational weaknesses, and also has been a barrier to being able to get access to the best talent possible for the agency. And so first key element of the new organization is that we rectify that. It's a handful of staff, 3 or 4 positions that we move over from the health policy shop into the health systems division, but it creates an integrated management structure for the Oregon Health Plan, so that we'll be able to go out and hire a Medicaid director who will not only be accountable for the whole program, but will actually control the resources and people and decision making in that process. It goes a bit part and parcel with some of the issues that we talked about in recruitment around how we structure decision making and documentation and those kinds of things, and I'll come back to that in just a minute. The more significant issue has to do with behavioral health. In an effort to kind of walk our talk, the agency several years ago made the decision to take what was the Addictions and Mental Health Division and break it up and put its pieces in about 4 different areas in the organization. And the idea was to break down silos that existed between behavioral health and physical health, and again, to sort of model the behavior we were asking coordinated care organizations and practitioners to model out in the workplace. I think a logical flaw in that thinking was the notion that integration in delivery of services should be mirrored in integration in what we do in the agency, which is actually different than delivery of services. It's policy and resources and those kinds of things. And the net result was it made behavioral health vanish from the organization. You couldn't find it, and there was no one accountable for behavioral health as an overall topic. And that's, in terms of numbers of people, the more significant change that this draft structure results in. Affects about 30 people, where we recombine many of the elements of what was previously the Addictions and Mental Health Division into a consolidated behavioral health program also within the Health Systems Division. We'll have a behavioral health director who will be accountable again and have control of all of the various elements of behavioral health to be able to deal with those issues. We're also going to specifically call out addictions programs as a focus area in that structure, and we're really trying to be conscious about talking about addictions in a broad sense rather than focuses on specific drugs or issues. We want to be able to transcend whatever is the most significant problem at any given time, and also pay more attention to issues related to alcohol addiction as they impact health. Those 2 functions will continue to live within a unified health systems division, and there's some conscious thinking behind that in terms of making sure that there's an actual role and a responsibility for doing that integration and making sure that those silos don't reappear between those 2 functions, so that we can continue to make sure that behavioral health, while talked about strategically in the behavioral health program, continues to be coordinated with the Oregon Health Plan, and we don't just recreate those silos. The idea, if you will, is to swing the pendulum halfway back rather than all the way back, which big bureaucratic agencies sometimes have a tendency to do. Also, one of the decisions that was made in the previous reorganization was to move the alcohol and drug prevention resources into the public health division. And again, we're going to try to swing that pendulum halfway back by leaving the resources in public health, but having them be matrix managed by behavioral health. So the people who do the work will continue to be prevention people because that's a core competency in public health, but strategically their work will be organized and managed by the behavioral health director. And that's a way that we hope to try to get the best of both worlds. Last thing I'll touch on in terms of the reorganization is we're at the same time doing a fair amount of work around a performance management system in the agency, which we had not previously had to a robust degree. And this is nothing fancier than the idea of being able to articulate mission, vision, and values, translating that into the focus areas of our work in terms of outcomes. What are the measures of those outcomes? How do we know we're driving better health care, lower cost, those kinds of issues. And then outlining what are the processes that we use in the agency to deliver those outcomes, and what are the metrics that go with those processes. It's in the absence of being a profit-making organization that's got a bottom line. It's how do you know how you're doing, and how do you know where things need attention. I've kind of, and we use the standard stuff you've seen in all kinds of tracking materials where you go green, yellow, and red. And I've talked about the power of yellow, which I think is maybe what we've been lacking in the health authority, is some kind of an indicator or an outcome or some area makes that first move from green to yellow. And catching it at yellow means you don't need to go past yellow to red to catastrophe. You're able to identify something when it first starts departing from where you want to be and begin to manage that process. And being able to document the processes, being able to track performance over time, be able to track decision making is the stuff that we're doing that's really pretty boring in terms of healthcare, but I think it's necessary to keep us out of crisis mode and focused on the important substance of the work we're supposed to do around things like CCO 2.0, improving health, behavioral health. And that's the topic I want to turn to next because it's closely
the important question. With all the king's horses and all the king's men, it is possible to put Humpty Dumpty back together again.
Assuming that this time he's a better egg than he was before, yes. So let me stop there and see if there are questions about the reorganization before I turn to behavioral health.
Yes, ma'am. Go for it.
Okay, thank you, Mr. Chair. I'm not sure if this goes to the reorganization, but I did follow Representative Nose's lead and read over your policy objectives, and I just want to comment with vigorous support for your integration and utilization of traditional health workers, and asking the CCOs to establish permanent structures to advance health equity, including, among other things, dedicating a high-level health equity position with budgetary decision-making authority, and also creating a plan for integration and utilization of traditional health workers. This has been an ongoing problem because we had passed a bill to create the Traditional Health Workers Commission, and there's a lot of good work being done to recruit and train health workers, and then they're not really being utilized to the full extent. And so various CCOs some are doing better jobs than others. Some have hired in-house, some are supporting community-based organizations. I tried to get at this with the bill last time around, and I'm just delighted to see it still on your agenda. I do have a comment about some of the reorg that you just talked about with behavioral health, but I'll wait until...
Well, let me just make a quick comment. I appreciate your support. I do want to point out that the things that you're seeing on that matrix exist right now at the level of these are articulations of the feedback and input that we've received. They're not decisions that we've made, right?
Okay.
So we're framing these up to be able to have a conversation with the Health Policy Board about them as potential items to be part of CCO 2.0. And so there's more work to be done, and I without doubt there will be issues around traditional health workers and health equity in the final sets of recommendations, but I don't want anybody to overinterpret these as done decisions as we sit at this stage.
I appreciate that, and I'm glad to see that you have captured that feedback because it's something I certainly hear a lot of.
Mm-hmm.
Okay.
You had a question about or a comment about the reorg?
You're about to talk more about behavioral health, so I can hold it till after.
Okay. All right. So shifting to behavioral health, and it's really it flows directly from the work that we're doing in the reorganization around behavioral health. I think one of the weaknesses to the approach that we've been taking for the last while, I think, in behavioral health is that, in essence, we as an agency don't have an opinion, and have not seen our role as trying to lead improvement and change and transformation in the behavioral health space. And we're not organized for it. And sort of the structures that we've been pursuing have been extremely collaborative, but I think have been lacking some drive to be able to transform systems. Those of a certain age and interest in football will remember Tom Landry, who was the coach of the Dallas Cowboys, who said something to the effect of, leadership is getting people to do something they don't want to achieve, don't want to do, so they can achieve something they want to achieve. And I think that's a little bit of maybe where we are in some respects in behavioral health. So, as a part of sort of that notion, we've completed some work inside the agency to get a better sense of, so what do we think? What are the problems that we see that we think need to be addressed in some ways to come at those? We're now beginning to widen the circle, and we've invited about 20 leaders in the behavioral health space in the Portland metro area, focusing on that geography, particularly in the wake of the closure of FamilyCare and some of the ripple effects that's had in behavioral health in that region, to begin to try to accelerate that conversation under the rubric of the Regional Behavioral Health Collaborative process that is part of what we've been doing for the last couple of years in this space, to really begin to figure out, who do you need to get in a room around what kind of a table to have what kind of a conversation, to really identify what are the most significant things we can do to make meaningful improvements in the behavioral health space, which we just desperately need to do. It's fairly clear to me, I've observed a lot, that I came to this job not knowing anything about behavioral health, and I've been there long enough to know next to nothing, but we've got challenges around lack of access to services, bad handoffs from one kinds of service to another, funding that's very patchwork and that often drives treatment more than what a patient's actual needs are, and a system that just overall is so incredibly complex it's very difficult for patients or their families to navigate under the very best of circumstances, and usually you're not in the very best of circumstances when you're trying to access this. So we need to get a lot more concrete and practical about what does fixing that look like, and so we're going to over the course of the remainder of the summer and into fall begin to have a very concrete conversation in the Portland metro area about what that looks like and what those changes need to be. Hopefully we'll be able from that process to have some learnings that can drive issues in other parts of the state. Even if we don't, we will have made the system meaningfully better for a quarter of the population, and that's a big get, and we'll begin to move from there. But that's where you asked Chair Greenlick for me to talk a little bit about behavioral health. That's where we sit today.
And you're recruiting now to
yes, we've
top positions, both positions.
Yes.
Okay.
All right, let me move on then. You want to follow up your question now?
Yes, thank you very much. Thank you. So I know in the metro area with the closure of FamilyCare, there's been a big issue not only with a lower reimbursement rate for behavioral health by HealthShare, but also a problem with a lot of pre-authorizations getting turned down. I know that there's some conversations happening about that, and it does make me think a lot about we've left a lot of leeway in our CCO development for innovation and trying different things out, and so we're at the point now with the 2.0 of how much leeway do we give, or how much do we try to like close in a little bit and be a little bit more directive. And so that's a question for a little bit for OHA, and as you look at your role and as you start to develop some opinions about some of that stuff. So I just want to say I'm a very active participant in that conversation, and it's both what are the decisions CCOs should be making, but also OHA. So just to get that out there in the public. And the other thing is with regard to the addictions that you talked about and the Alcohol and Drug Policy Commission, I've been delighted that you've taken a much more public health, and I understand that you're trying to have both a public health approach and behavioral health, so it's sitting somewhere perhaps in between. I am delighted that we are moving toward a public health and treatment view of addictions as opposed to a public safety view. And in that vein, I know that there's several people that are being nominated and to be confirmed tomorrow. I hope that we continue to put people on that commission who have a very strong background in the health prevention and treatment side. And so as we move forward, I hope next year's batch of nominees bring some of that strong health-related background.
Appreciate that.
It would also help if it met on a regular basis instead of missing 80% of the meetings the last 2 years while we're having an epidemic in the country.
Or meet at all.
What's that?
Or meet at all.
Or meet at all.
And we'll certainly do our part in terms of providing support to that commission and working to integrate that. I do want to comment. We have a lot of balls in the air right now. I think it feels like we've moved a bit out of crisis mode. I have no doubt that there are other things that are likely to surface, in the months ahead, because it's not been that long that we've been trying to focus on this. But as our work on crisis management ebbs, what we're able to really do is focus much more on this structural and strategic body of work. And these things really do all flow together, from a performance management system that identifies what our key outcomes are, to being able to articulate what our objectives in behavioral health are and convene those players, to the CCO 2.0 work and how all of that work informs what we do in terms of coordinated care organization contracts. That stuff does all kind of hang together as the fundamental strategic and structural work we need to do to be able to, I think, get the agency hitting on all cylinders. And I feel, while it's an awful lot of stuff that we're trying to manage right now, I feel very hopeful that we're on the right track, and we're spending time now doing the right stuff that will help us accomplish that. Unless there's anything else on structural or behavioral health issues, I'd like to move on to open card data.
Go ahead.
So this is the question and the hardy perennial issue of how many people are on fee-for-service, or actually we prefer open card. Fee-for-service is actually a term that applies to a bunch of things that are appropriate for people even who are on the Oregon Health Plan, where there are certain services that are carved out from what would be provided by a coordinated care organization and are paid fee-for-service. So open card are people who are not associated with a coordinated care organization. And this data gets a little bit dense, and I apologize for that. So stop me at any time if I blow by a point too quickly. But there are a number of kind of bases of who are we talking about in this case. The very broadest number is this 1,080,000 people, which is the total medical assistance caseload. Not all of the people who are in this caseload have access to full OHP benefits. There are a bunch of different categories of benefits. I won't try to go into the details of that. But at that highest level, there are about 22% of those 1,079,000 people who are on open card. The open card population itself then breaks down into three main categories. The really important one, I think, to pay attention to is the pie slice on the left, that are the 93,000 people who are not enrollable. They cannot enroll in a coordinated care organization, and there are a variety of different populations that this falls into. The Citizen Alien Emergent Medical Program, CALM, is an example of that. On the right-hand side, then you have two different categories that I'll go into some detail. You've got people who are enrollable but have exemptions that cause them not to be necessarily required to enroll in a CCO, and people who are enrollable without exemptions. An example of those who have exemptions are tribal members who are not required to enroll in a coordinated care organization. Some do, some don't. Collectively, the tribe's preference is that their members not enroll in coordinated care organizations and instead have their care managed through the contract they have with Care Oregon. And this just basically shows those populations. And the enrollable on the right-hand side, I talked about tribal at 15,000 members, dual eligibles, third-party liability, that's where you're on the health plan, but you were also in a car accident, and the auto insurer is the one who's paying for the claims. You've actually got the largest category is people with more than one category of exemption. So they may be a dual eligible who also has a third party payer. And then this takes the enrollable population, so we're down from that 1,080,000 people to who is enrollable. It's 960,000 people, and about 15% of those who could enroll are not enrolled in a coordinated care organization. And this graph really is the punchline. There's a churn element to people who are on open card because of the period of time when you first enroll in the Oregon Health Plan or are redetermined into the Oregon Health Plan, that you initially spend a period of time on open card and then roll over into a coordinated care organization. The line on the bottom is the rate of retroactive enrollment in the Oregon Health Plan. It's the green scale on the left. The blue line, which has the scale on the right, is the percentage of open card enrollment. You can see that these two numbers actually track together as we have at the point that we had a fairly high retro rate, which included the period that we were working on the backlog of redeterminations. Similarly, the open card rate was high. And as those numbers have trailed off, they've trailed off more or less in tandem. The very steep drop in the open card percentage at the very end is a little bit misleading. One of the other challenges when you look at this data is there's preliminary data and then final data. It takes 90 to 120 days for there to be final data. And typically the numbers will increase as we go through the retroactivity period. And so 3 months from now, if I'm looking at that last line on the graph, I would expect it actually to be a couple of percentage points higher than it is now as we get through that retroactive activity period.
Representative Hayden?
Thank you, Chair Greenlick. On your, I think it was 93,000 and change on the enrollable with exemptions that aren't in the CCOs, how big is that population? Meaning, is that half of people that have exemptions enroll with the CCO, or what is it 75%, 25%?
Enrollable with
so they're...
Yeah, that's a good question. I don't have the answer to that at my fingertips, but I can get that.
Okay. I just want to see what the penetration by CCOs, are they trying to get them enrolled? Are they making efforts to, or?
Yeah, we can get that data for you.
Thank you, Mr. Chair. I have three kind of questions that I'm a little bit embarrassed to ask because they feel very basic at this juncture in my career here, but I'm going to ask them anyway. Is it a choice to be in a CCO or to be an open card?
Generally, you've got to fall into one of the exemption categories to not be enrolled in a coordinated care organization. You then, in certain geographies in Southern Oregon right now, have a choice of which CCO you would be in.
So then my next question is, do we sort of think it's better to be in a CCO?
In general, that's the policy guidance that we have, and that I agree with it. It's better to have your care coordinated than to.
Okay.
And it's better for the individuals because they have more access to care.
All right. So then here's really my real question.
Also, maybe less expensive.
Yeah. So then, why not just automatically enroll them? Why have this open card period? If they're eligible, put them in a CCO.
I believe that the answer to that is that it's not quite as easy as that at the point of enrollment to know about exemptions and geography. And so there's a period of time where that situation sorts itself out. It's a couple of weeks typically.
Really?
So it's almost instantaneous, but it's not quite. And so that number ends up looking artificially high. And that's really the point.
Some people come in already needing service. That's the route they get in. They show up at the hospital.
Mm-hmm.
But don't we say, where do you live? And I realize sometimes people's living situation is transient or unclear, right? But that's not so many people, is it? I mean, is it really that high? This is part where I'm a little embarrassed maybe to be asking this out loud.
I think that's the right question.
You know?
You're talking about the 48,000 that have no exemption. Why is it that high?
Well, I'm just, like, if we think it's better to be enrolled in a CCO, why not just automatically enroll them?
Yeah.
And I get that maybe their living situation's unclear, so we don't know which one they would get, or, I sort of understand that, but it just seems like where we can automatically enroll, we ought to just say, that's our practice, we automatically enroll you.
Yeah, and one of the challenges is by law, what you have told us is that when someone has been disenrolled and there's a retroactive re-enrollment, that they retroactively re-enroll to open card because there's a negative selection window in there that can occur where services happened in that period of time before re-enrollment. And so that's a statutory decision that, as I understand it, that you've made, that when someone is retroactively re-enrolled, they go to open card.
I don't remember that.
We should try to figure that out.
Check that one out.
We should try to figure that out.
We can come back and talk more about that.
Yeah, I agree they should be automatically. Representative Nelson?
Thank you, Chair Greenlee. I had a question about children. What percentage of this are children, and specifically with Cover All Kids coming on? Other than there's always children that have disabilities that may need the open card to access services, how is this all going to impact the numbers once kids all get enrolled?
Yeah, so I can't tell you the breakout with respect to kids. We can get that data for you. I can tell you that the population related to Cover All Kids continues to be pretty small. It's about 4,000 kids, about 3,000 of whom were rolled over onto the program from other programs, and the uptake has been steady but slow, and that's maybe not surprising given the current environment around issues related to immigration status. But I don't think Cover All Kids by itself is going to be a significant driver, but let me work on getting you the data about kids on and off
Curious to see that. Thank you.
Representative Hayden?
Thank you, Chair
That may
Greenlee.
be the last question.
Okay. So I asked your predecessor, and then when you first got involved, you said you'd work on it, didn't have an answer. My question, I think, is pretty basic. Of the, for example, 48,000 that should be enrolled, they don't have exemption, or the 93,000 that could be enrolled, what is the per member per month cost of open card versus cost to CCO? I've been asking that question do we know the answer to that yet?
Phrased that way, we may. I think previously the conversations have been the cost of fee-for-service, and here's where open card versus fee-for-service really does become a different issue, because there are things paid on fee-for-service for members in CCOs. But we can work on that breakout of cost on open card versus not. The cost generally should be lower because the reimbursement rates on fee-for-service generally are quite a bit lower than through coordinated care organizations.
Well, I extend that to fee-for-service, too. I'm still curious as to if the state pays widget by widget versus the coordinated care organization, where we think that they have less access to care.
Right, but when you go into the fee-for-service realm, you start mixing people whose care is being paid for generally with people who we very specifically want to buy those widgets widget by widget, and so you can't roll it up very easily. But we should be able to roll up the open card versus not, so we can work on that.
The basic assumption we made all along is that if you had everybody involved in an open card versus a managed care, the managed model should be less than the uncoordinated care. But when you're dealing with little chunks of their time, you can't tell. Depends where they are in their efforts. I think
that concludes everything that I had on my list.
Includes everything on mine, too.
Okay.
I just do want to make the one comment for future reference. There was a recent Commonwealth report on healthcare in the states. I think we had it sent out to all of you. And it showed as a state we did pretty well. We moved up, I think, 10 places or something into the top 10. But we were 51st in the country on one item, and that was childhood immunization.
Really?
Yeah.
I missed that.
51st.
Yeah.
50 states, we were 51. I guess there's something else in there. I think that's something we really need to be talking about. It's an issue that I think is really important. I'd like some time on it. I'd like to give you all and your public health people a chance to think about.
Yeah, and I think you do have a presentation on all this. We just realized we were going to run out of time today.
Well,
We'll get to that.
And I think we need to have some discussion about that. It's an important issue.
happy to come back and talk about that.
I also want to point out that in the public health modernization process, the Public Health Division had an approach for how to spend the first amount of money we gave them. I thought it was the wrong approach. I fought them on it for a while. I went to the Public Health Advisory Board and again told them I thought it was the wrong approach. It was an approach where they spread out the money across as many counties as possible to do a single thing to deal with the communicable disease program. I was absolutely wrong. The work they've done has been quite extraordinary. They've gotten into 34 out of 36 counties. They're doing things in every county. I've worked with them to try and make sure our colleagues understand what's going on. Because it's pretty hard to get a concept of what public health modernization really is, and what the heart of it is. And I think what they did really moves us really well forward. And I think I need to commend your people for that.
Thank you.
Thank you all very much. It has been a weird day for us up here. Maybe tomorrow will be less weird. We're adjourned.